morning. We're here this morning with Dr. David Potenziani, who is the Interim Associate Dean for Information Technology, Planning and Coordination here in the School of Public Health at the University of North Carolina. David is also an adjunct professor in Health Policy and Administration in the School of Public Health. So let's begin with just telling us a little bit about sort of what your roles are here, Dave, because we obviously have several of them.
I've discovered that there are very few things that don't fall within my job description. If there's a problem, I tend to be the person who gets assigned to deal with it. I've been in this position just a couple of months, and in that time have moved from being a firefighter to starting to build and consider systems of fire prevention. It really involves the administration of the School of Public Health, which is not a small enterprise. It is a $100 million budget in terms of most of that for research, much of the rest for supporting educational programs, but we also have service and outreach functions. And so this office is coordinating a lot of that effort through the administrative staff of the Dean's office. We have 7 academic departments, several other support units that all their efforts are coordinated through the Dean, through my responsibilities. So in a way, we're in charge of everything and nothing at the same time, which is typical in higher education. We tend to organize based on academic discipline, and the challenge there is that the challenge is twofold. One is, a lot of times those disciplinary silos require support services that are redundant to the department next door. The other challenge is, quite often you get people who in one discipline talking to their peers here and elsewhere, but not to the person on the next floor. And so you get interesting conversations that I've seen happen where a behavioral scientist will sit down and have an encounter with an environmental scientist. And they will discover that they have actually been dealing with the same set of issues from different perspectives for years. And then there's that moment of recognition and shock that, my God, we're brothers or sisters, and perhaps we should do something together in the future. So part of the job is actually to facilitate that as well. The school has a few institutional approaches to help with that, but a lot of it is just being a sort of like a honeybee, cross-pollinating through the garden.
That's fascinating. So this this whole notion of interdisciplinaryism that sort of begins to pervade the academic culture and modern life. You're let's take the honeybee. You're the horticulturist who is trying to facilitate that, and I know you must be good at it because UNC has been very successful with the NIH roadmap.
Well, I can't take any credit for that.
Well, but I mean the culture here, I think,
right,
is the thing that allows that to happen. So, I mean, how do you make that work? So you had the example of the environmental scientist and the behavioral scientist who now have this sort of discovery. Oh, we have something in common. How do you sort of encourage and nurture that and support it from the dean's office?
Okay, and for example, this spring, one of our named lectures, the Ford Lecture, this is an annual event, school-wide event that brings in a leading person in public health, and we've had high-level people from the World Health Organization for the Centers of Disease Control, and this spring we had a person in from the World Bank, John Briscoe, who is their water quality person assigned to Brazil. He's worked in easily a dozen countries around the world. He gave a tremendous talk where he comes to water issues from a physical scientist perspective, but in his work in the World Bank over many years, he came to recognize that water technology is not enough. You can't build infrastructure just by focusing on, well, if we had these sorts of latrines that we were able to pay for building them in India, that we would solve some problems of sanitation out in rural areas. What he discovered, as with the rest of the World Bank, is you needed to take a behavioral approach and focus in on the messages that you wanted to provide people who may or may not see a latrine as something they want to use.
Right.
And so what you do is you focus on the behavior, and then you provide the infrastructure that supports it. Well, there were behavioral scientists in the audience who were getting very excited about this, and the place buzzed for days about, golly, maybe what we ought to do is talk to the folks from our Department of Health Behavior and Health Education, talk with the folks downstairs in the Environmental Sciences and Engineering Department, because they know all about the physicality of water quality and sanitation and so forth. But clearly everybody understood that there were issues here that by combining types of expertise, you could do things that were more successful and more scalable than before. So part of it is engineering, in a sense, encounters like that, where you get 400 people in a room, they hear this message by this leading person who really is not just important in the role he plays, but he's a thought leader as well. Okay, so that's one type of example. Another programmatic approach that we've used in the past few years is something we call conversational living rooms. One of the advantages now with our new atrium is that we have furniture type, living room type furniture spread around it in these clusters that are meant to be encourage conversation. And in a way, it's become our living room. And so every few months we have we invite faculty to just be available, perhaps with a poster or some other kind of visual aid that can explain some of their research, and then people can circulate. It's late in the day. It's meant to be relaxed. It's meant to be informal. And the idea is to just get people across disciplines asking questions. Quite often it's the students who are the most useful in providing the connections between these things. And in some ways the students are ones who are probably most susceptible to these kinds of transdisciplinary approaches. So in that sense, the school has been trying to foster this kind of effort. A lot of it is also the leadership in the person of the dean, Barbara Reimer. She has a monthly lunch with 3 or 4 researchers where each one is asked to give her an overview of their research. And it's always surprising, because she'll find out that Gary Rozier in the Health Policy Department, he's a dentist by training, but he's doing work on adolescent issues, pediatric issues in fact, of dental care that have long lasting effects on the health of children.
Interesting, yeah.
Well, we had never heard that before because we didn't necessarily subscribe to this or that particular journal. But giving him 10 minutes to talk about this, and Barbara is very good at setting an example, a very courageous example of asking the naive question. So it's sometimes a very simple, straightforward question, but it's very efficient because she learns so much in the next minute. So sometimes, actually, faculty members who are put together, and these are all over the map every time, they will come out of that encounter, that lunch encounter, and say, we should talk, the two of us, to consider doing some research project or service project together. And so collaborations have come out of that. Public health is a difficult area because it's a collection of disciplines. You have social sciences, psychology, sociology, education, etc. You have physical sciences, such as engineering for environmental issues, as well as bench science for micronutrients in the brain and human development and nutritional issues. We do genomic sequencing. We do health policy, which is, in some cases, econometric studies.
Right.
Our Department of Biostatistics, they cross the barriers between theory, development of theory, as well as practice, where they're training people in how to deal with large data sets. In epidemiology, we're trying to understand disease outbreaks and patterns and how to address them. And so, with that mix of disciplines, it's unlike any of the other health schools. Medicine, dentistry, pharmacy, nursing tend to have a unitary curriculum, and we don't. We have 5 core courses that every student has to take in order to get one of our degrees, but beyond that, when they move into their concentration, they could be working in very different areas.
Right.
So it's an ongoing challenge to help connect the dots across the school. The one area that, and this comes out of my previous experience as the IT director in the school, the one area that is common to all public health is data. It is an approach to human issues that's based on evidence, specifically based on data. It began with epidemiological approaches in the 19th century that matured in the early 20th. And so what people involved in public health are interested in is data, but until very recently they've not been that interested in information systems.
Interesting.
Okay.
Yeah.
And which, from my perspective, I find very ironic. But then perhaps irony is the most advanced and latest of human emotions. And I think the entire disciplines of public health collectively have come to understand this. About 4 years ago, the Federal Centers for Disease Control and Prevention started a network of people called the Public Health Information Network. This was in part a standard-setting effort for understanding disease surveillance data, outbreak data, and to be able to standardize that in terms of messaging as well as normalization nationwide. And they've had very significant success in terms of trying to link outbreak data to clinical laboratory results and the like. And so this is at a very high level and in some ways rather abstract, and it hasn't quite reached ground level. The state of North Carolina, for example, over the last 3 years, the State Division of Public Health has worked on 6 or 7 different information systems. Some of them involved disease surveillance, some of them in terms of clinical information system, because local health departments do provide clinical services for many people. Some of them in terms of environmental surveillance, etc. But these are state-level systems that are a bit like rain in the desert. It sometimes doesn't reach the ground. Yeah. And you see it coming down, it looks promising.
Right.
And so one of the other issues is from the other end of the spectrum, and that is the folks on the ground. There are 86 health departments in North Carolina. Most of them serve a single county. There are a few that are clusters of counties. But the local health department directors have, on their own, come to understand that their information system needs aren't being met locally. Individually, though, they don't have the resources to be able to address these, because quite often the health department is funded by the county government, and the county has a lot of other things that are contending for their funds. So they have, on their own, self-organized in some cases. There are about 5 different, they call them incubators, which is an interesting term.
Right.
And these incubators are sub-regional. They represent clusters of local health departments that have said, we're going to work together in this area. It could be the Piedmont. It could be Western North Carolina. There's a pretty robust one in the northeast part of the state. But the idea was to share information about their situations and occasionally be able to say, well, if we pooled our resources, we could do this thing. We could go to the Division of Public Health and say, well, we like this about your clinical information system that you're making available to us, but there are some other concerns that we have, issues in functionality that it may or may not have that we need. And so what's happening is you see all of these parts organizing themselves, thinking about information systems, because the information system they've become aware is important in using the data and getting a much better sense of what's going on. Now, this has also worked in a different domain. There's a program called NCDetect that is, what it does is every 12 hours, all 24 major emergency departments in the state upload data to a central server. This is first chief complaint data from these emergency departments, with not much more than that. But the idea is it's identified data, so you understand the individual involved, you understand all the circumstances of that encounter with a clinician. But that data is then evaluated using a model called syndromic surveillance. The idea is to look for patterns in the data that are precursors for an outbreak of avian flu, of perhaps poisoning, anthrax, etc. And to do so before even the clinicians are aware that there is some kind of event. It could be man-made, it could be a natural event, but the point is to get ahead of the curve. And so what we see is a great but fragmented appreciation for information systems. And so one of the things that your dean and my dean have talked about is, well, shouldn't we start training people in these kinds of issues? The 21st century, I think, is going to some degree, there are two attributes that are going to be salient. One is the importance of information systems and data. The other is networking of all kinds, social networks, data networks, organizational networks, professional networks, functional networks. And if we can combine these to understand both domains and take advantage of what each of them brings, then we're better able to deal with the problems we're going to face, because the issues aren't going to get simpler, and they're going to continue to be challenging. And so if you have an evidence base that you can draw on, if you can make sense of phenomena based on data, that's really what public health is about. And it's just applying some of those things that are common in other domains in the domain of population-based health. So I've spent a good bit of time over the years teaching students who tend to be, my students tend to be mid-career professionals. And it's been in quite an education for me. Occasionally I'm only just a little bit ahead of them. Occasionally they're a little bit ahead of me. What I've seen, though, and this is interesting in the realm of healthcare management, is that it's changing very rapidly. When I started teaching this course in 2000, I was orienting these people. There are a substantial number are MDs, a lot of nurses, a lot of people who work for healthcare payers, insurance companies, a lot of people who are management in medical centers and hospitals. And so with that rather eclectic mix in healthcare delivery, in 2000, they were interested in, well, they had never seen inside a computer. So I developed a lesson on gross anatomy. And we took computers apart and talked about the pieces and the functions. They didn't understand what operating systems were. They didn't understand the difference between operating systems and applications, much less what kinds of applications would be useful for you and your job. Okay. And so their information, their knowledge needs at that time were very basic. Well, the last time I taught the course last fall, we were deep into data standards for clinical systems. We were talking about the growth of new types of applications like personal health records and what does this mean. We were working in the various legal issues involving exchanging of clinical data and what are the limitations, what kinds of legislative changes need to be made, what's the case law, and so on. So the issues on the ground have become quite different over the last 7 years. One constant that I've had was to ask the students to organize into groups and each one develop a request for proposal based on a real-life issue they were facing at work. And it was meant not to do an off-the-shelf solution, but rather something someone would have to configure, invent, adapt.
Right.
And initially it was very simple kinds of things. And the latest types of systems these students were talking about had to do with linking clinical information systems together for managing, it sounds prosaic, but to a hospital it's very important, utilization of beds.
Right.
You know, how do you know your inventory of beds? How does it relate to the issues that patients have? Diagnoses are important because when you move from one patient to recycle a bed, you have to do certain things in certain ways and so forth. And so this is a huge business issue. But it's one of a rather sophisticated set of approaches that links a lot of things together. And so what's happening on the ground is that health information technology is rolling over the American healthcare industry, flattening things in some cases, confusing things in other cases. And one of the problems that these medical centers and hospitals face is none of this is cheap. There are a lot of zeros in these acquisition budgets. And a lot of people, what I have found is I've had a number of medical center CIOs talk to me and say, I come at this from a background in information technology, and this is my first job in healthcare.
Right.
And so, on the one hand, they don't know enough about clinical issues that their customers are facing, their physicians, their nurses, their administrators. And so they spend a lot of time catching up on that to understand the context of information technology in that sector. The people in clinical practice in administration are saying, we don't know enough about information technology. We can see that these information systems might be helpful, but it's very difficult for us to evaluate this versus that, this approach versus that approach. Where do we make our investments strategically? What makes sense? And quite often, what happens is every hospital and medical center keeps making the same stupid rookie mistakes. They create their own system when they should buy something off the shelf and adapt it. Or they fall prey to the sales patter and they buy a system and then realize later, oh, it doesn't really do everything we want. Or they don't understand that once you buy it, you've only started paying for it.
Right.
And so you have all of these business issues that are coming into play. And so I see these as huge opportunities to educate people, to train them, understanding how to use these systems. And so far, we've only made fragmentary progress along those lines. Very, very few people in public health, because of those disciplinary silos that I mentioned, are conversant with enough of these developments to understand what they might mean. Everybody understands websites now. Everybody understands email now. But they don't necessarily understand data systems that underlie them. They don't understand the ability to roll up data. About a year and a half ago, this again was one of those things that Dean Reimer did. We had a Dean seminar series. And one of the speakers was Dennis Gillings, president, CEO of Quintiles.
Right.
And he gave a speech where he talked about the importance of data. And he said that up until now, we have had success in public health in dealing with issues of sanitation and infection. But that the very success of those efforts have lengthened lifespans.
Right.
And so because of that, the issues we face now are a different set. And these are more chronic diseases
Right.
diseases and conditions that emerge because of patterns of behavior that span decades.
Right.
Cancer, heart disease, diabetes, obesity.
Right.
These are incredibly difficult issues to treat medically,
Right.
but on a population basis, they're even harder because you have such a wide variety of people involved, of situations, as well as you're fighting time because it took 25 years for the person to realize they had heart disease, realize they had cancer,
Right.
and yet their behaviors were a contributing factor to that, as well as a host of other kinds of issues. And so his perspective was the only way we're actually going to address these more intractable issues, more complex issues, is being able to use data, and data of all kinds. He advocated a universal approach to data in the sense that economic data can be shown to have a direct correlation with health outcomes, with the assessment of health of a community.
Right.
It's sort of common sense to think poor people get sick more often, but poor people get sick in certain patterns. And so the question is, if you have a variety of data that you can look at, you may be able to understand some of those patterns and be able to address the issues. For example, the NCDetect system is able to get data from these emergency departments. That's great if somebody who has avian flu shows up there.
Right.
But they may not be sick enough or poor enough to have to go to an emergency department for that kind of care. And so if they go to their primary care doctor down the street, as far as the public health system, unless the doc recognizes this as an infectious reportable disease, they're invisible to the system.
Right.
So if we were able to have the medical system, the information system that clinician uses, allow us to roll up data in the same way the NCDetect system does, then we would have a much better sense of what goes on, not just for detecting an outbreak or some other kind of problem, but to help us understand what's the health status of this community. What are the issues that they face where we can target our meager resources in a way that is more effective, cost-effective as well. But that at the moment, we're collecting this data in these isolated buckets in some ways that don't aggregate because they're on different types of standards.
Right.
And we have very little facility in being able to pull this data together to connect these dots. So there are federal efforts in Health and Human Services to facilitate the adoption of health data standards in clinical systems. But it's still a very complex process, and in North Carolina there is a group called NCHICA. It's a nonprofit, North Carolina Health Information and Communications Alliance, that tries to foster connections between the health affairs community, the clinicians, the people in public health, etc., and the health information technology industry, the people who create electronic health records, systems, etc., as well as those who are involved in clinical trials from the pharmaceutical industry, from the contract research organizations and the like, to try to create this sort of clearinghouse of information about what's going on, and trying to foster the development of a statewide regional health information organization to facilitate moving data across the clinical landscape, to be able to use it for disease detection, for community health assessment, for recruiting for clinical trials. I mean, if we could connect even just clinical data, the number of applications and approaches that would be helpful are staggering that we could do. But we are a long way away from doing that. Part of this is helping educate the clinicians in terms of, if you buy this clinical system versus that clinical system for your patient information, you need to ask some questions as to, well, if your practice combines with another, will your information systems align? If you need to provide information to state or other agencies, can you do so? Can you mine your data? Because you may have candidates for clinical trials. And so a lot of physicians or people who are involved in the administration of these practices and hospitals and medical centers are just now beginning to ask these questions. And the vendor community is just now beginning to adjust and move into ways to fulfill these needs. So, it's a long answer to your first question.
That's fantastic. I was making some notes here about sort of starting with the theme of how do you support collaboration, and there were several kind of interesting links or threads. There's the notion of kind of an infrastructure, the atrium example. There's the notion of human talent, students who take classes in multiple places and sort of serve as a bridge and a glue, lectures that sort of bring people together physically to hear ideas. There's the IT infrastructure that sort of serves to facilitate communication. And then the overall notion of a culture, the culture that is sort of allowing and encouraging this kind of collaboration. And this last example that you were giving of the NCDetect is an interesting one, because you would say, well, of course this is a good idea. Why can't we just get all this stuff? What are the barriers? And you didn't explicitly say it, but it's not a technology issue. It really is an issue of data standards and of changing the culture of the way we think about information and the sharing of information in today's world.
The other challenge, though, is more diffused and based on what human beings are. One of the books I read a while back was The Physiological Basis of Human Consciousness by a Nobel laureate. And that and another book by Greg Easterbrook about sort of where the human species is at the moment in terms of social organization and the like, allowed me to connect a couple of dots. Part of this is there seem to be some synaptic limitations as to how many personal relationships a human being can manage. That is, in the sense of having a true relationship with another person. This is important in that it seems to suggest that the scale of human interactions seem to be limited at about 150 people, meaning that human beings individually can have strong and meaningful relationships with about 150 people. I think it's no accident that that's about the size of a prehistoric tribe. Okay?
Yeah.
And that there are some places, some organizations that have leveraged that, maybe without understanding any of the anthropological or physiological or social behavioral issues. The Gore-Tex company, for example, tries not to have a hierarchy. And they organize themselves in 150-person units. And when a unit is successful in a business sense and they start growing, they recognize that they're getting too big and they split. And the idea is, behind this organization is to understand what those other people can do. It's not who you report to, but rather who can help you solve a problem you have today, who has the expertise, who has the experience. And so if you know that Mary has that experience on the other side of the building and you've got this problem, you go talk to Mary.
Right.
Mary says, well, if you did this.
Right.
And so what that scale of organization allows is that set of human networks that can leverage expertise across the society. The question is, what happens when you get above 150 people? If you get much above that, then what you tend to see are hierarchical organizations. Military organizations, of course, are the most obvious example, but higher education is a very structured hierarchical organization with many centuries of experience and funny costumes to boot.
Right.
But what that in many ways suggests is that we need to foster human networks so that we understand what the capabilities and the abilities of other people are, so we can use them to solve problems. Sometimes we do this in a formal sense, especially when we have an opportunity for a grant proposal that allows us to put together a multidisciplinary group. And that's, every one of those I've been on, whether it has been funded or not, has been beneficial.
Right.
Because people learn the other people, as well as something about the other disciplines. And I think if we could foster that kind of relationships, perhaps in some ways in a self-organizing sense, then I think as academicians we can have a tremendous impact because we're leveraging the resources we already have. We're just not as aware of them as we need to be.
That's fascinating. That's really interesting, and a kind of a nice upbeat vision for where we can go.
Right. Right.
So I think with that,
You got enough?
I think this is fantastic. Any final thoughts or comments?
I couldn't imagine what they might be.
Well, again, we'd like to thank you very much for talking with us, and look forward to more conversations in the future.
Thank you.